Good morning. We welcome you to the June 2nd Board of Health meeting. Glad to see all of you, no matter where you are and how many things you've seen yesterday. To begin with, we have the Board of Health minutes for May 5th. May I have a motion for their approval?
Ray will move to accept.
Okay, Ray moves and a second.
I'll support it.
Okay. So I didn't see who supported, sorry.
Joe?
Joe, okay, Joe, thank you.
Good.
All right, any discussion of the minutes? Hearing no discussion, may I have all in favor?
Aye.
Opposed? Motion carried. All right. So we do have the vouchers, and so we can go through those. If you have any questions, is there anything you want to highlight on the vouchers? Jennifer? If you'll unmute, please. Welcome.
So there was only two that are over 5,000, and those would be related to business as usual, our medical director contract, and our contract with Mosaic to house individuals related to COVID.
All right. Does anyone have any questions about the vouchers? Thank you, Jen. May I have a motion for their approval?
So moved.
Okay, Dr. McBride moved, and is there a second?
Ray will second.
Ray, second. Thank you very much. Any discussion? All those in favor?
Aye.
Aye.
Opposed? Motion carried. All right, we have two resolutions.
Yes, so we have two resolutions to approve, and then there are a few others that we'll talk about a little bit later, not for approval today. But one of the ones that has already been approved by the Board of Commissioners since we last met is related to this first one. So this first one, it's Resolution 237. This is a resolution to enter into a contract with the United Way of Southwest Michigan. It's a grant subrecipient contract relationship or similar to that. And this is part of a grant that we were awarded from Michigan Health Endowment Fund to the Michigan Association of Local Public Health. And there was a requirement that 80% of the grant go to a community partner as part of the work plan. So we accepted that funding, I believe last week, might have been 2 weeks ago, with the Board of Commissioners so that we could get moving on that work plan. But essentially what we're doing is we're endeavoring to work with the United Way of Southwest Michigan to really mobilize a large group of volunteers and others to do some community canvassing and influence communities and individuals who are still deciding about the vaccine and doing it in targeted manners that get at some of our geographies, some of our census tracts that do have lower vaccination rates. We do have some variability in that geographically. So the United Way of Southwest Michigan has some things that are going on that already fit that through some of their funded partners, through their ability to mobilize volunteers. So this seems like a pretty natural partnership for this grant opportunity afforded to local health departments to work with a partner. So our contract with United Way will be for the period June 1 through December 31st, and it will be a payment of $40,000. Our total grant award from MALF and the Michigan Health Endowment Fund was $46,000.
All right.
Good thing. I have a question just because I think it's a great thing to do. I'm just wondering, how do they do that? Knock on doors, go to, what is the process? Because I think that is important to reach those communities. Just curious.
Yeah, and I'm going to invite Jillian or Courtney to jump in at any point, but I mean, we're trying to model this a little bit after the, Rock the Vote campaigns. We're trying to get people registered to vote or trying to get people to take the census. Those are other efforts where you're trying to go really deep into the community, trying to have some of those individual points of dialogue. I think some of the specific strategies are still coming together, but Jillian or Courtney, if there's anything you would add to answer that question.
Nikki, can I add a question to that? Maybe they can answer or respond at the same time. What's the product we're providing with that amount of money?
So, I mean, I guess to first jump to Joe, your question, I think, as Nikki said, some of it is still formulating. We have some meetings set up with the United Way, but really kind of picturing that community canvassing where we have community members who are from communities being able to touch their own contacts, their own networks, be able to deliver a message in a way that will resonate with those who they always are hanging out with, or being able to be that trusted person. Some of that could actually look like door hangers, door knocking. Sometimes it might be being out and about at community events that are happening or common community gathering places, kind of thinking that same model of like being in the barber shops or being at grocery stores or whatever that might be, where that normal community gathering place is. I guess, do you want me to, I can jump a little bit into, right, so that money that we're contracting with United Way can be used in a couple different ways, but really it's for stipends and compensation for those who will actually be doing canvassing and outreach. We're asking people for a service and to use their networks and their skills and their experience. And so it will be able to compensate people for their time, for mileage, maybe driving around the county. We know our county requires car and transportation. So being able to pay for things like that. Training. So one of the roles that we will continue to hold with the United Way will be creating kind of an outreach vaccine champion or ambassador, are kind of the words we're using, toolkit. So putting together outreach materials, being able to host trainings, having all of the materials put together to ensure that those individuals who we're recruiting to be vaccine champions feel comfortable in the message that they're delivering, that they can answer those questions, that they have those resources. So it'll be for doing some of that things, as well as supporting clinics maybe, or outreach for that, doing mailers, things like direct door mailers, door hangers. So maybe you weren't there when canvassing happened, but a door hanger can be put up. So print materials, those types of things will be able to be supported.
Great, thank you.
All right, if it's the pleasure of the board, I would like to have the other position described as well, and both of them approved at the same time. So
the next resolution for approval, for your consideration for approval, is resolution number 241. And this is to create a new full-time position at the health department with some additional funding that has been awarded to us. We have been running a HIV program. We've had a community health worker position that has been doing a lot of outreach, some case management, really making sure that we have HIV infected individuals appropriately linked to care, as well as doing a lot of preventive activities. So the state of Michigan has granted us additional funding, which was accepted last month. It's about $50,000 is that award, but we need another community health worker to be able to expand the work as is expected from this funding. So we are asking to add another community health worker. It's a grade 7 union position. Add this to our complement so that we can do that expanded scope of work within our HIV program.
great. We need this. Are there any questions? All right, I'm really thrilled that we're moving on this. This is great. So we have two resolutions before the board. May I have a motion for approval?
So moved.
Okay, Joe has moved. May I have a second, please?
Ray will second.
Ray, second. Any discussion? All those in favor?
Aye.
Opposed? Motion carried. Just thanks to the staff for all the innovative things that you do in addition to the other resolutions that were approved by the county. We're really pleased. All right. We're moving on to some recognitions and one retirement. Boo-hoo. So, all right. So a recognition of Karen for 5 years.
Yeah, so, and just to put it, Karen has actually worked for us longer than 5 years, but 5 years is the clock for when she was an official, like, permanent position. So she's been with us, part of our team, and had more years of service than that. But I'd like to turn it over to Donna to get us started for recognizing Karen.
Thank you. I've had the pleasure of supervising Karen for the past 2.5 years. I've been here 2.5 years. Karen is part of our immunization team. She is always willing to orient and mentor new employees, new staff. She also is our school reporting nurse. Schools report to Karen. And then probably the biggest is the past 1.5 years with COVID. Karen has always been willing to step up and work extended hours, work weekends, holidays. She's been willing to work to do case investigation, contact tracing, and most recently our COVID vaccine clinics. Karen has always been willing, has been there, and is helping to lead the team. I think what I most appreciate about Karen is her dedication and the knowledge that she brings to our team. She's a true asset to Berrien County Health Department.
Thank you very much, Donna. I appreciate you too.
Thank you very much, Karen, for all the work on the vaccines and everything else. Wonderful.
Thank you. Thank you very much.
Thank you, Karen.
All right. Moving on, we have a retirement of Ruthie. How could she leave us?
I know. And so Ruthie actually retired last week and opted, or her last day was last Friday, and she opted not to join us at 8 a.m. on her, in her first week of retirement. But Aisha Finley has been her supervisor for the last 1.5 years or so. So I'd like to turn it over to Aisha to say a few words to honor Ruthie.
Hello, everyone. Ruthie, she has been with the Berrien County Health Department for 16 years. She was very dedicated to her job, and she was just all-around person to be with, to work with. So we will truly miss her. So,
yes.
Yeah.
Absolutely.
Yeah. I personally appreciated Ruthie, so she was a joy. So thank you, Aisha, for talking about her skills.
Yes.
All right. So moving on, Jen, to the Berrien County Financial Report, Health Department.
Absolutely. So this report is for the period ending April 30th, 2021. What we will see is for state and federal grant revenues received through April, we are $641,000 over budget and $1.2 million higher than last year. A majority of this funding is related to the extra COVID funding that we received. Permits and inspections are favorable to budget by $80,000 and favorable to 2020 by about $27,000, primarily driven by septic tank revenues that have been higher than we expected those to be.
Mm-hmm.
Medicaid, Medicare, private insurance, and clinic revenues are unfavorable to budget by $27,000 and down $25,000 compared to last year. Medicaid Title 19 reimbursement is $144,000 favorable to budget and $80,000 higher than last year. This increase is primarily driven by carryover dollars that we have not spent yet. Related to expenses, our overall direct expenditures are $145,000 under budget before the county allocation and $727,000 higher than the previous year. A majority of the increase is driven by increased personnel expenses related to the COVID hotline, contact tracing, and vaccine clinics. Our personnel-related costs, including both salary and benefits, are $78,000 under budget for the current year. This favorability is primarily driven by benefits being budgeted at the highest potential expense per employee. For example, they budget at full family versus if somebody just denies insurance or does it for a single individual. Let's see. Personnel-related costs are $646,000, approximately higher than the prior year. Medical and program supplies are $69,000 favorable to budget. This is primarily timing driven as we do the federal vaccine entry only once a year in the fourth quarter. Contractual services are $11,000 favorable to budget and $22,000 favorable to prior year. This favorability is primarily driven by the redeployment of resources to COVID, and regular programming has not been executed as normal. Primarily NFP and 4x4. Travel expenses are $18,000 favorable to budget and $12,000 lower than the previous year. This is driven by our travel restrictions. Insurance expenses are $14,000 over budget and $9,000 higher than the previous year. This is timing related as we have already made 2 of the 3 payments required per year. Software maintenance expenses are $27,000 over budget at this time. Again, this is timing related due to the fact that we paid the Patagonia maintenance agreement earlier back in February. So let's see here. So in summary, our revenues exceed the budget by $725,000 and our expenses are favorable to budget by $236,000. So this yields $962,000 favorable budget variance for April.
Well done. Are there any questions?
No.
No? All right. Thank you very much, Jen,
you.
for grasping the budget that fast and catching the questions that are always about and worry about salary. So that helped explain that. Very well done.
Thank you.
All right. Moving on to the administrative reports.
Yes, thank you. So we will go ahead and start where we usually do with the data, just to give you an idea of where we are in the pandemic. This is an EpiCurve. It really shows the entire course of the pandemic going all the way back to March of 2020. You can see here that since the beginning of April, we've been in a pretty steady and pretty rapid decline in our number of cases. And we're now averaging under 10 cases per day being reported to us, which is phenomenal. We really have not been this low since August of last year. So lots of things potentially contributing to that, but we're pleased with where we're seeing our case counts. If we look at percent positivity is continuing to decrease and we're getting down around 6%. So again, I mean, that makes sense. As you have fewer cases, your percent positivity is going to go down. And when we look at the amount of testing, we are seeing a bit of a decline. We have been relatively flat for a period of time in terms of testing, and there's been a bit more of a gradual decline. It started to increase a bit more. We do start to see testing demand go down as our number of cases go down. This is not entirely unexpected. I do believe there are other things driving this, though. There seems to be a general sense amongst the general public that the pandemic must now be over because masks are not required for vaccinated people and there's changes in capacity limits. The pandemic is not over. But I do think that that has contributed to a little bit of a sense of maybe not seeking out testing. However, we also know that there's a seasonality to this respiratory virus, or at least that's what we observed last year. So it's also just possible there are less symptomatic people out there right now with any respiratory viruses, therefore seeking less testing. When we look at our hospitalization trends, you can see that that has been in steady decline as well, pretty much since late March, early April as well. So very pleased with that. That is our biggest, and best canary in the coal mine to let us know what's going on. And things look well throughout the whole course of this second this latest peak that we had here. We did see fewer ICU admissions. We're continuing to see fewer deaths. So that is all good. And the fact that the hospitalizations continue to decline is really a good thing. And then just looking at the death trend, you can see when we're here, we're at an average of 1 per day, and we have been pretty much well below that for several weeks. So there are still some COVID deaths that do happen. COVID is still circulating in our community. Vulnerable people are still vulnerable to some of the severe outcomes that can happen with this, but we're very encouraged that throughout this spring sort of uptick, we never really saw a big uptick, significant uptick in the number of deaths, and definitely think that can be attributed to the rapid vaccination coverage of our most vulnerable older adults.
Do you have any explanation for there's been some recent publicity, negative publicity, on the deaths in Michigan and the count? You know what is behind all that? I don't really understand it.
I don't, and I'm not really sure. I know that there have been a couple articles now that I have read, and it sort of seems like the headline doesn't always match the content of the article either. But I don't think that I have no knowledge of some new cases or deaths or something that had not yet been reported. There has actually been very robust death reporting with a very wide net to catch anything that could potentially be a COVID death. So I'm not aware of any actual data issues or things happening that are leading to some of the assumptions or conclusions of maybe there were more deaths, especially in nursing homes, than were previously reported. Some of it, if you go way back to the beginning of the pandemic, I'm sure we probably were doing some underreporting of both cases and deaths just because there was such a lack of testing available. That was when there were the swab shortages. You had to be really severely ill to be tested, a lot of those sorts of things. So I can't speak much further than that on that issue.
Thank you.
You're welcome. So shifting gears a little bit just to look at vaccination rates. This is a map of the state of Michigan by county, and this is showing the percent of the population that is 16 or older and has received 1 or more dose of the vaccine. So as the pink becomes lighter, it increases. As you flip to green, that's where you have crossed that 50% threshold. And then darker green is a higher percentage of people that have been vaccinated. So Berrien County within the last week or so flipped over that 50% mark. Some of these, depending on which dashboard you're looking at and what features and age groups you have clicked, that might not jive. I know the state's vaccination dashboard is showing us closer to 46 or 48% when you take 12-year-olds into account and put those in the denominator. So if people are seeing some conflicting numbers, it could be based on what age group is included in that denominator. But very pleased that we've crossed that 50% threshold. I hope to see some of that increase. Now, we are able to internally break down some of this a little bit further by census tract. Not necessarily to go super deep into any of this right now, but if we look at just adults 65 plus, virtually every census tract, except one, is over 50% of adults 65 plus have received at least 1 dose of vaccine. So again, true testament to the fact that we've got pretty high rates of vaccination amongst our older adults. When we look at adults just 16 to 64, we start to see a different picture. There's fewer of our census tracts that have even gotten to 50%. So we're using this to help target some of the efforts, especially the work we'll be doing with United Way and other partners to really target and get into pockets of the community that maybe have not been targeted sufficiently yet or had access to the vaccine. So you can just see there's a little bit more variance here when we're looking at those younger adults. They have had less time And then when we just look at it for 16 plus combined, you can see there's a bit more green, but I think this is a truer picture of how we need to target our efforts if we remove that population that has been already well covered. And then up here in the right corner, this is just a map of the social vulnerability index. You may recall that we talked about this a couple months ago, but there were some efforts to try to make sure that we're targeting vaccine access specifically to communities or census tracts with this high social vulnerability index. That is an index that is composed of many indicators. I think there's more than 15 indicators about whether or not a community is able to kind of quickly rebound from some sort of crisis, whether it's a natural disaster, a pandemic, some sort of crisis that happens in that community. So it takes income and jobs and transportation and housing, and there's lots of different factors that go into this index. But there's 4 categories listed here. So is it a low social vulnerability index, low to moderate, moderate to high, or high? And we can see that there is a little bit of overlap of where we've got more of the blue are some of the areas where we continue to have some of the pink when we're looking at adults 16 to 64. So all of these things together are helping to drive some of the decision-making as to where the vaccine is accessible. The complicating factor here is this is all based on census tract of residents, but we know people don't live their lives in the census tract that they live in, and there are lots of other places people are going. So that does make targeting things a little bit trickier, but we're definitely working through that. And I know we've talked about this at previous board meetings, but there really is a shifting vaccination strategy. You recall those first 3 months, it was just get shots in whatever arms, try to manage everybody that is trying to get in line because we had a lot more demand than we had supply. We have long ago reached that inflection point where we have more supply than we do demand. And so we've really shifted towards we're managing our inventory, keeping our expiration dates in mind. We still definitely want to be good stewards of the vaccine. It is a precious resource that we want to make sure is used well. But at the same time, we're also valuing if somebody wants to come get a vaccine, no matter what, we're going to make sure they get that. We've talked about a little bit, we are going deeper into the community, trying to make some new connections. We've had, as a health department, great relationships with community partners, but when you're trying to get to everybody, there's a lot more depth and there's a lot more opportunity for us. So we're continuing to push to that. And then we are really working to create those consistent opportunities to be vaccinated at convenient times and locations, convenient for the public. So we have standing evening hours. We've worked really hard. Every Tuesday, our health department operates vaccine clinic late afternoon and into the evening. By having that consistent time and location, we're hopeful that that will help people. A lot of people are just looking for convenience, or it's like, I don't necessarily want to do it today, or they might want to work it into some plans. Knowing when that's going to happen reliably will help with some segments of our vaccine convenient population. But we're also still other days of the week going into community locations because we know physical proximity, being in trusted locations, trying to overcome transportation barriers or just convenience also matters a lot. And so we're also endeavoring this summer to have some of those locations pair with some of the community canvassing that's happening. So if we're having a targeted effort in one community, we're also going to make sure the vaccine is available there around the same time. There's a flurry of messages about getting vaccinated there. And a lot of that is just leaning into work with trusted partners. And those are partners that are trusted by the community. They might be new connections for us, but building that relationship. And again, those meaningful connections in targeted locations. And so with this shift in the vaccination strategy, I wanted to revisit something that I had shared with you. This is historical, this is as of March, but I had shared with you that there were kind of 6 buckets of work and what some of that detailed as a health department, because COVID's really important. COVID has required a ton of attention and resources and effort. It's not the only thing, and there are many things that we as the health department do that nobody else is doing. And if we aren't doing them, it's going undone, and that can only happen for so long. So here we are in June, and we're going to talk through this in a little bit more detail at our next meeting in July. But just to give you a little bit of a preview, we do still have the same 6 buckets. Those are all still relevant, but the proportion of time and effort and resources into each of them has varied. And really this continuity of operations and getting back to, I hate this word normal, but getting back to kind of the normal programming, the non-COVID programming, and ramping that up has been a really important factor for us. And some of how we've organized ourselves for some of the other COVID-19 things has driven that, so that we can make sure that we have the staff and the resources available to make sure that our families are getting the support that they need, that WIC clients are getting the support they need, so our environmental health team can meet this. There's a lot of pent-up demand out there. We have some of our services where we've just lost some clientele over the last year and a half because everything's been shifting. So we want to make sure we're rebuilding that. So we're trying to lay that runway for what the health department is looking like post-pandemic, late-stage pandemic, and beyond. So some of the content of each of these buckets has shifted a little as necessary. But like I said, this is just a little bit of a teaser. We're going to go into more detail about that in July. And then the last thing I just want to leave you with, and I'm sure many of you, I mean, the changes in some epidemic orders and guidance, it's been a couple of weeks now, but some pretty seismic shifts have happened since our last board meeting. And I think for me, my headline and what I want to make sure everybody hears is the pandemic is not over, and we are actually in this really messy middle period. The messy middle period offers a lot of hope, and I think we should focus on that hope and be optimistic about what is to come, but without throwing caution completely out the window. So public health interventions do continue to be very important. This has never been all or nothing, and it's not all or nothing right now. As we've said before, interventions are more like a series of dials where some of them you need to crank up, some of them you need to crank down, some of them you just have some fine-tune adjustments. As we are all aware, there has been changes in masking guidance, particularly for unvaccinated or for vaccinated people, but even outdoors, unvaccinated people are okay to be unmasked. Our epidemic orders have changed to reflect exemptions for fully vaccinated people, although there are certain carve-outs that make it so that masking can be required in some situations. So it's not like the mask is completely gone. But as you start to have less masking and less social distancing, which is a fantastic thing that we get to do with our high levels of vaccination rates and so forth, that is really good. But that means that some of these other things, and this is not exhaustive, but it becomes even more important that we continue to exclude ill people. So doing symptom screening, staying home if you're ill, really paying attention to what's going on with you, not going to work to be that martyr who goes to work when you're sick, but really making sure you're staying home. All of those things are just increasingly important as we don't have a mask there as a fail-safe. Testing, isolation, quarantine, all of the case investigation and contact tracing activities we've been doing, those grow in importance as we have fewer cases out there. That becomes a more useful strategy for being able to stamp out lines of transmission. That activity will be ongoing for quite some time. But again, it's important if you do think you're ill, stay home, except to get a test, and being tested, and then isolating if you're positive or while awaiting those results, quarantining if you've been exposed. All of those things continue to be really important, but we still have all of this great opportunity to be able to see our loved ones, to be able to attend events. There are events that couldn't happen last year that can now based on gathering sizes. So I think we're in a really hope-filled time, and there's a lot on the horizon that we can be looking forward to, that we can be enjoying now. But at the same time, we need to remember it's not all or nothing. We do still have a pandemic happening. If you're not yet vaccinated, we really need you and want you to get vaccinated to protect yourself and to protect the community. Jillian, is there anything you would add to any of this last slide here?
No, not really. You covered it really well, Nikki. Like you said, I think there is a lot to look forward to. And if you walked around yesterday or even over the holiday weekend, you probably saw a lot more people not wearing masks than you might have been used to before. I think one other message that we are just really trying to encourage our community is to be respectful of the decision that people might be making to continue wearing a mask, even if they are fully vaccinated. Be just aware of the different locations that you're visiting, the establishments you might be frequenting, because individual workplaces and businesses can make more restrictive rules and have those in place than what is set forth by the state. So we've just been encouraging folks to, be aware, be respectful, and carry a mask with you just in case if you've been fully vaccinated and need to put it on, at the last minute. But otherwise, there's a lot to look forward to this summer. And like Nikki said, we're really hopeful for the direction we're going in.
Great report, guys. Great report.
Mm-hmm.
Two
Thank you,
questions, if I could ask.
Joe. Uh-huh.
Well, one thing I read that people that are immunocompromised, and even if they get the vaccine, it's not that effective. So maybe that particular subgroup should be advised to, maybe still wear a mask. I also understand that, like myself, we had it down in Florida, and I believe you had some kind of communication that needs to be counted somehow. At some areas it may not be, and you were trying, because that would show an undercount, I guess. Another question was the need for a booster. Maybe a good doctor can update us on that, whether the efficacy, how long this thing lasts, and that would be helpful. And then I read, I apologize for all these questions, but if you've had the virus, they were saying, oh, you need to get another shot, or you should get the vaccine rather. And then I was reading recently that some of the studies show that no, you don't need that, that the immunity you seem to be protected quite well, and maybe don't need the vaccine. So anyway, those are a few of my questions.
Yeah, so I'll take a stab at addressing some of those. So I think you're right with the immunocompromised individuals who are immunocompromised, just by nature could have a less robust response to the vaccine and therefore have less coverage. It's important for those individuals to really consult with their healthcare provider about their specific situation. But yes, immunocompromised individuals might need to exercise a little bit more caution, even if they have been, quote, fully vaccinated. In terms of the out-of-state vaccinations, it is important to make sure that if you did get your vaccine out of state, that it is reported in our Michigan Care Improvement Registry. That is the registry where all the vaccines are recorded. Yes, it helps contribute to our percentage, but also it then becomes searchable by anybody who might be providing you healthcare here in the state of Michigan. And that is also really important. So anybody could take their vaccine cards or their official vaccine record, whatever you have from where you got your shot. You can take that to your primary care provider, or we have a process here at the health department. So you will be asked a few things to be able to verify so that we can make sure that you truly were vaccinated. There is definitely a market for counterfeit vaccination cards. And so we're making sure that we are doing all of that appropriately, following all the state guidance for how vaccines are getting entered, but there absolutely are processes for that. I don't know, nothing definitive has come out from the CDC or MDHHS or anybody about a booster and a need for a booster. I think we need a little bit more time to continue so that we can see what immunity levels look like for the people that participated in the clinical trials, since they were the first ones vaccinated and have therefore had this longer. I don't know if Dr. Kowalska has heard anything different or has been following that research just yet. I think the jury's still out on that one.
I agree with you, Nikki. There's mainly anecdotal evidence of folks who have had COVID-19, the illness, becoming vulnerable once more as they pass the six-month mark. I've seen that in skilled nursing facilities where someone had COVID in the first wave in May, and actually seemed to come down with a second a second infection out after 7 or 8 months and actually passed away from that. It's not clear whether it was COVID, directly from COVID versus just COVID accelerating their disease process. So yeah, we just need more time with the folks that have been vaccinated. I think there is an argument for those who've had natural COVID might actually have a more robust response and immune response, assuming that they don't have immunocompromised states. So yeah, only time will tell, and we just need to hope and pray that the folks that are doing the research will publish those results in a timely fashion. So it's good that there are boosters that are being worked on to cover the variants that we've seen. The current vaccines still have some effectiveness against those variants. I think instead of 95%, it's down to 88%, but that's pretty good still. So I think there's good reason for hope, and we, the academics and industry need to do due diligence to stay on top of these things. So.
Thank you. Joe, did we get all your questions?
Sure.
I feel like I missed one.
Thank you. Appreciate
Okay,
it.
good.
Nikki, quick question. Do we have any breakdown on the variants, number of positive variants from our statistics for the county, or we're just calling everything COVID as they're turning up positive?
So the whole process for identifying the variants is not everybody who's tested gets tested for a variant. So there's a certain percentage of samples that are sent from some of our labs. These are also from PCR tests, not rapid tests, I believe. So that's already kind of narrowing in. But some of those specimens do get sent to the state lab. We do have between confirmed by the lab and then their contacts who were also confirmed to have COVID, but maybe their specimens were not tested. We have in the ballpark of about 50 to 60 known variant cases in the county. But based on how those are tested, that's not really an accurate number to hang our hat on. What we can say with confidence is that we do have variant strains here. It has been almost all the B117 variant, which is the UK variant. And that has actually really gained a foothold throughout the state of Michigan and other states in the country as well. But that variant is definitely here. The major hallmark of difference with that variant strain is really about increased transmissibility, not necessarily causing more severe illness. But if you have more people who are infected, you are going to see just higher numbers of people with severe outcomes because it's a numbers game.
Thank you.
I just wanted to thank you, Nikki, and you also, Jillian, for all the media work that you're doing. I mean, it's just superb. It's calm, consistent message, and I know it must take a lot of effort. So thank you so much for the way you convey information, both of you. Proud of you.
Thank you, Peg.
Mm-hmm. All right, if there are no more questions about our COVID-19 update, we have 4 resolutions. Do I understand that they were approved by the county board? Is that the case?
So 3 of them, the first 3 listed on the agenda have been approved. And the 4th one we plan to take off cycle probably next week. So the first one with the contract with King Media, this is resolution 228 in your packet. We have had a contract with King Media and worked with them. I think this is the 3rd year with our Dirt on Weed campaign. And this is part of funding we get from Lara to do education around medical and recreational marijuana. So we have a campaign that we've developed with King Media. They were selected as a vendor through a competitive bid process the first time we worked with them. And so now we're contracting with them again. I do believe this is a joint project with the Cass Van Buren Health Department again. Yes, Jillian?
It's the Van Buren County Community Mental Health this year.
Thank you. That's right in here. So that way throughout our region, we have a little bit more reach. We're pooling our resources, but the Berrien County portion of that contract is 39,000. Berrien County's portion is 25,000 for a grand contract total of 39,383. So then the next one I spoke to a little bit earlier. This is the acceptance of funding that originates with the Michigan Health Endowment Fund. It was awarded to the Michigan Association of Local Public Health and then MALF. And MALF is now granting some health departments this funding. So the health department accepted $46,000 in a grant award through this process, and that is the funding that we're using to contract with United Way of Southwest Michigan, as we spoke to earlier with the resolution you approved. So that went through, and then we have resolution 235, and this is actually the contract for medical director services for Dr. Kabaltica that went into effect yesterday. So that was approved by the Board of Commissioners last week. This fourth resolution here about a staff complement update is we're working through, and we've got just a couple of details left that we're working through with personnel and the union. But we do have a medical social worker position that has been part of the Berrien County Health Department complement for many years. That Kim Kepler was the employee filling that position. She retired a few months ago, or late 2020, I believe. And that position has been vacant since then, as we wanted to be able to take a little bit of time to think through what we needed in that position and get ourselves to a place where we could do some effective hiring and onboarding. So given the fact that that position, the job description has not been updated, the title has not been updated, all of those things have been reevaluated and will be shifting so that the classification or the job title and description are a little bit different. So this would be a resolution that would delete the medical social worker and replace it with another position that does work in the same vein, but the scope of work is a little bit different to meet the ongoing and evolving needs of the department and the community.
Just speaking from one of my part-time jobs with Neighbor by Neighbor, I've really missed the health navigator function. There are other health navigators in the county, but not nearly as effective as Kim was. So I hope that function will continue. It's so needed with a number of people who do not have medical insurance. Yeah. It's complicated. So thank you for placing this. So
yeah. Thank you for that feedback. So those are those contracts or resolutions off cycle. And then I think we did a very brief introduction at the beginning of the meeting, kind of buried here in the middle of the agenda, but we do have Dr. Kabaltica, who is officially with us right now. We're very pleased that he is part of our team now. Dr. Johansson will finish his service next Monday. So we've got a little bit of overlap here to make sure that we're getting all of the administrative logistics tackled to make sure we can have continuity of operations in our clinic. When you've got one medical provider, that a lot of things are happening under that license, the transition is certainly, there's a lot to it, but we're working through all those steps. So I'm very pleased to have Dr. Kabaltica with us. And Dr. Kabaltica, I'd love it if you'd give the board a brief summary and introduction of yourself.
Just really thankful for the opportunity to join the team. I know that Rick Johansson has physically much bigger shoes than me, and I look forward to trying to step into some of that. But I hope to be a little bit more nimble, perhaps, than you might physically be. So there's a lot for me to learn. There's just this one meeting has brought up a lot of just insights into the good things that are happening. So I hope to be able to engage more fully once I learn what the health department needs are, and just glad to be on the team. So look forward to working with you all.
I had the pleasure of being part of the interview team with Dr. Kabaltica and a couple other members, and I just really appreciate your racial equity lens coming to the community. That's very important. I mean, you were by far the best candidate. Nobody was anywhere near you, so we're so glad to have you on board. Thank you.
Thank you.
All right. Moving on to the spotlight on programs. There's Guy. I didn't see you before.
Yep, so we're these three all really dovetail to one another. So Guy's gonna go ahead and get us set up with some of the data and the context around substance use. Lisa will then talk about what her department is doing and some of the activities to address some of that need. And then Jillian will get into a little bit more of the specifics on the Dirt on Weed campaign. So I'll just turn it over to Guy.
Hey, thanks. I'm going to try to share my screen. I put together a few slides for today. Let's see. I have them up, so let me just grab them. Can you see this okay, Nikki?
Yeah,
Yes,
we
we
can see
can.
it. Thanks.
All right, so we're going to talk about substance use disorders. I'm going to go through some national kind of trends, what's going on, and then kind of end with Berrien County and some facts about marijuana that we're seeing in really younger generations. For references, my sources are all listed here. A lot of this is just a direct dump from the CDC. They have these drug use statistics that are available free to the public. And that is primarily what we're going to go from, looking at a lot of these national trends. Overall, just looking at Michigan, where do we fit in the number of age-adjusted rates for drug overdose deaths? We are number 21. We are in the dark green. So we have, as you would say, a little bit more of an issue than the rest of the nation. We have on average 24.4 deaths per 100,000 population in the state of Michigan, and that ranks us as number 21 in the nation. Some of the quick stats we're going to go through here. The following charts that I'm going to show you are going to be through drug death information and kind of what is the cause, the leading causes behind a lot of these drug deaths. What is the trend we're seeing throughout really from 1999 to 2019? And then what are some of the major contributors to this increase in drug-related deaths? So figure one is the national drug-involved overdose deaths. So the key characteristic here is the number of deaths has been going up over the past few decades. Here you see that we have male and female broken down here. It is a little bit more prevalent among males, but overall from this graph, we are seeing an increase. What is the cause actually of a lot of these deaths? And you see synthetic opioids is really taking off, and we're seeing an increase in that. We're seeing an increase in a lot of the other drug-related deaths down here too, but synthetic opioids is by far outpacing the rest of our drug-related deaths. The overall, overdose deaths involving any opioid, this is kind of breaking it down just a little bit further in what we're seeing. With opioids, I just want to stress that the trend here is increasing. And as we have seen, these are national numbers that are increasing. I will get to Berrien County local numbers. So prescription opioids, I think that was a campaign we also been trying to fight a little bit. That's not outpacing the rest of them as compared to synthetic opioids as it has been in the past. I think a lot of our campaigns to reduce the amount of prescription drugs that are hitting the community is responsible for decreasing or flattening this number a little bit. You see that it's actually the past few years has somewhat of a downward trend, that's a good thing. So that could be part of our efforts in reducing prescriptions and monitoring closely opioid prescriptions. The national deaths, however, involving heroin has increased a little bit, and this is heroin in combination with synthetic opioids. So I know there's that kind of, what is it? It's a saying that's kind of out there, like this is not your grandmother's grandfather's marijuana. It's getting much more potent. Well, this is the same thing with a lot of the drug deaths we're seeing. It's not what we had seen in the past, where it was typically maybe just a heroin related death, but now heroin and other narcotics are being involved. They're kind of being adulterated, and they're being mixed with a lot of different things. So this yellow line is actually showing heroin in combination with other synthetic opioids, other than methadone. But that is kind of a trend we're going to see here too, with a lot of this drug-related death, is that a lot of these deaths are starting to involve other things, other combinations of things in there too. So one of the bigger contributors in what we've been seeing a lot out of the drug-related deaths are these psychostimulants, and that has had a significant increase in the recent years with what we've been seeing nationally. Psychostimulants have been causing more deaths. We're finding that they're being used more often as well. Okay, these are breakdowns. I don't need to get into all of these too much. This is just looking at cocaine, drug deaths involving cocaine, what that's looked like, an increase in yellow there. And then again, stressing this is in combination with other synthetics. And then looking at this one too, benzodiazepines in combination with other synthetics has had an increase. And then lastly, we have antidepressants in combination with other synthetics has been increasing as well, where antidepressants without any opioids has remained pretty consistent throughout history. So that data is available for you guys to break down, to look at a little bit more. I think we do want a little bit more of a Berrien County focus. So looking at, this is from the medical examiner's report out of Western University School of Medicine, who does do our medical examiner cases. They break these down every year for us and offer us an annual report. This is in that annual report. So Berrien County accidental deaths by mechanism, you see drug-related is in here. 23 last year, and in 2020, which is the most recent data, we saw a 10% increase to 37 deaths, and that is 10%, not just the actual number, but we are seeing a significant increase in drug-related deaths this past 2020 most recent year. So that is a little bit concerning, and we do have that available in the same national kind of statistics where things break down like that. The last thing last two slides I want to show here are substance use disorders. The age-adjusted rates for drug-induced causes of death. This has a little bit of a racial focus, racial disparity here. You see that the drug-related deaths for whites is significantly lower than the drug-related deaths for Blacks, and that is provided by the Michigan Department of Health and Human Services. This data is, like I said in the beginning, at the sources. In both of these categories, both of these racial demographics, we do see a bit of an increase throughout the past few years, especially looking back, 10 years ago, 2009, 2008, we're seeing a lot more drug-related deaths. And then the last thing I was asked to focus on a little bit more was marijuana use. And I think one of the most important demographics we have to look at when we look at marijuana use is really school-age children. What is the more vulnerable brain? The higher consequence is going to be in this population. So let's see if I can make this a little bit bigger. The data here is from the drugabuse.gov. So this is either funded through the National Institute of Health or through the CDC, and it breaks down on national levels, what are we seeing in terms of youth and drug use or marijuana use. I did throw vaping and nicotine up here because if you look at this red category over here, the percent change, I think I compared 2017 here to 2020. Obviously, vaping has become more available, but we have 44% of 12th graders reporting that they have used nicotine for vaping in their lifetime, which is a significant, I'd say, increase in that. I'm looking at, and I know Lisa and her group deal with vaping quite a bit in your day-to-day activities. And then I did break down vaping with marijuana and then marijuana in itself. And you do see vaping with marijuana has increased, and it's likely because it's harder to detect if somebody has been vaping some type of marijuana substance versus smoking the actual plant itself. One leaves a much more distinct smell than the other one. So you would imagine if you're trying to conceal that as maybe a 12th grader or or even an 8th grader, if we've seen this increase quite a bit, you would see kids using vape pens more often. The gold highlights are significant increases in use. So from the previous year. So looking at this one, this is a significant increase from 2019, the amount of vaping marijuana use in 12th graders. So I wanted to, kind of set the floor with what we're seeing with drug use nationally. I think a lot of the national numbers, we're going to follow similar trends in Berrien County. As you see, our drug deaths did increase. The national drug deaths is increasing. Unfortunately, I don't have Berrien County specific marijuana use in schools. Usually that data comes from the Youth Behavioral Risk Factor Surveillance Survey, which is kind of an opt-in only when you're studying participants under the age of 18. So I can hand this off, or I can try to answer any questions.
I have a question. Is 2020, might that be a blip because of COVID, where people are cooped up and anxious and that kind of thing? I know we won't have any data on that, but I don't know what the expert thinking is about that.
So the one, that's a good question, Joe. So the one nuance they did have in this data, and I didn't include it in this presentation, is that the 2020 data is a smaller sample size, but they believe the extrapolation over the population that they did to adjust for that smaller sample size is still applicable. That's still a really good statistic. The question is, do people smoke more, or do they turn to more substances during the COVID pandemic? That could be a causation of the increase, but it wouldn't deny that there's an increase.
So Guy, I had a question about the national data, and you can just tell me not to ask it if you prefer, but I saw that some of them were with methadone, or methadone was involved. And I just had a question about why methadone was part of the discussion. Is it people taking drugs on methadone?
Yeah, so I'm not really sure why they included that. Maybe Dr. Rex, if you have any insight into that, with what you know with methadone as a controlled substance, I can't really predict. Maybe it's trying to show any correlations with treatment.
So, and I'm happy to hear what Dr. Kabaltika has to say as well. I think sometimes methadone is used because somebody who's on methadone is actively trying to reduce their habit and their dependence on opioids. And that's what methadone is used for. So if you look at what's happening, you might be able to get an understanding of some of the I don't want to say the success of the treatment, because that's not quite it, but that is a little bit of a factor. This is somebody who has sought out treatment and is trying really hard to do the right thing.
Okay. I see Ms. Lisa or Dr. Kabaltika. Yep.
I think one of the things that you see with someone who's gotten on methadone is that they're at least admitting to one substance of abuse. And that's rarely the case that there's only one substance. So there's probably a mix of other things. That's just the opioid side of the equation. You probably have some benzodiazepines that are in the mix there, and alcohol as well. So all those have an interplay. I'd say that when you have someone that's using methadone, then there's probably other substances that they're also struggling with. So that's one. That would be one explanation. I actually have a question for you, Guy, once we get through this topic.
Guy, Bob Harrison. So on the national level, did they look at states that have legalized marijuana versus states that have not, and the incidence of school-age children, active users? Did they break out the data nationally at all?
I didn't see that in this presentation. I'm sure there are studies being done, especially because some states have had legal marijuana for some time now. But I don't have those figures. I'm sorry. Okay. I can get those.
All right. Thank you.
Miss
Good
Lisa,
question,
were
Peg.
you, Ray, just a second. Miss
Sure.
Lisa, did you want to say something? I saw you.
Yes, I just, before I get into my part, I just wanted to echo what Nikki was saying. The treatment providers in Berrien County meet on a regular basis. And with regard to methadone, some of you may be familiar with Harbortown. And Harbortown is a methadone assisted facility to have someone who is an opioid user reduce use. So that might be another factor in why you see some of the increase with that particular population. So.
Thank you. Okay, Ray, sorry to interrupt you there.
No worries, no worries. Guy, any comment on with the increased availability of Narcan? We still have a lot of opiate overdoses. Any correlations we're seeing of what really the numbers may have been without Narcan, or has that been factored into any of these studies? Do you know?
I don't think that was in the data that I presented, the Narcan discussion. Obviously, an increase of deaths over the past few years is not great, saying that Narcan is saving lives. From what I've heard anecdotally about Narcan is that they've used it several times on people, which means they keep resuscitating the same person with different calls. And Lisa, you can probably speak to that. The Narcan use, we don't have any figures in front of us, but I'm sure you can speak to what we're hearing with Narcan use in Berrien County.
Absolutely. I'm trained, and so is Shannon Larry Burton, in Narcan training to the scare me tactic. But what we're seeing is the sheriff's department or sheriff's office is reporting that they do get repeated calls for the same individual. And I think it was last quarter in the sheriff's report, there was one individual who received that treatment 13 times.
Oh my God.
So we still have a lot of, we're into saving lives and we're into providing emergent responses when we need to, but then we need to then carry on the work as far as preventing repeated use.
Guy, if I can give you my question now. There was a slide that you had that broke it down. I think it's substance use related deaths between races. And there was actually, it looked like there was a period 3 or 4 years ago for 2 or 3 years where it looked like there was actually equity. Probably not equity, because I don't know if those statistics were per 100,000 of population of that minority versus just absolute numbers. But can you go back to that? Yeah. Where it looks like from 2006, from 2006 to 2008, it actually went down among the African-American population. And then it looks like there's equity. This is just age-adjusted death rates. And is it per 100,000 of that population or per 100,000 of the overall population?
It's population specific. So yeah, it's actually showing, you could say equity in the context in those situations where the two graphs are about equal.
So
you go back to like 1999, there's a big gap between them, right? And then it kind of narrows in the 2000s, and then we're starting to see it widen again. That's an interesting note.
Yeah, so I'd like to know what was happening in those years that there was relative equity. I mean, you don't want to see a trend upwards, by any means, and yet at least it looks like there was something good happening between until about 2017. Then after 2017, I don't want to make any comments about the political situation during those years, but wow, kind of wondering, what contributed to that relative equity. So yeah, I'd like to discuss that with you at some point.
All right. This is fascinating data. Unfortunately, we have septic appeals process is going to come after this meeting. And so I unfortunately going to cut things short and just keep focused on the time that we need to finish this meeting about 9:30. So Lisa, do you want to go ahead with your presentation?
Sure. Good morning, everyone.
Morning.
So just giving you a quick update on our public health promotion and prevention program. As Guy stated, you saw an increase in opioid use throughout the nation in the last 5 years. And so we have been receiving a SOR grant or state opioid response through our funder, SWIMBA, to address specifically those things, but also carrying over into other areas of substance use disorder prevention. So the first program that we were able to do this year is Guiding Good Choices. This came out of some additional SOR money that was granted to our department. And Guiding Good Choices is a 5-session program that teaches parents of children aged 9 to 14 how to reduce the risk of their children developing drug problem. Each session is between 2 and 2.5 hours long, with sessions meeting monthly. The program is based on more than 30 years of research conducted at the University of Washington, and then 20 factors have been identified that increase young people's risk of developing problems with drug use and problem behaviors. If you go to the next slide, we had the opportunity post-COVID to work with our first cohort at the Boys and Girls Club on the FEDIC Youth Campus. And these are the 7 moms plus myself who completed the first cohort. And it was absolutely the greatest group to have as far as being engaging and also really seemed to embrace those parenting behaviors that they can increase their interactions and communication with their children. In fact, one participant felt so good about our camaraderie that she bought t-shirts for everyone at our last session for this photo. So we hope that we're going to have another cohort very soon, starting this summer again. This particular pot of money is for work only with the Benton Harbor Boys and Girls Club. And so we want to continue to tap into parents there. Next one. Also, part of the SOR money that we received in the last 5 or 6 years is a program called Project Toward No Drug Abuse. It's an effective drug abuse prevention program that targets youth ages 12 to 17 that are at risk of drug abuse. It's based on more than 2 decades of successful research at the University of Southern California. So with this particular intervention, this is a selective population of students. So those that are already at high risk. And so the program was developed as a group session, but it can also be done in individual sessions. And that's primarily how we've been doing it. It's facilitated on an individual basis, and classes can be held twice a week for 4 weeks. And those are facilitated by program specialists, our prevention specialists. Next slide. 3 ways for a youth to be referred is school referrals. So say a youth is breaking the school rules in some way, or maybe was found on school property with a substance as a condition of not suspending, or maybe suspending with this intervention. A school can notify us for a referral. A parent themselves, if they notice some troubling behavior in their child, they can also refer for the service. But our most popular way is court referral. So if the court receives a petition from a police agency and feels the juvenile would benefit from this program, the court will notify the parent of the juvenile to schedule TNDA with us. And currently we have a very robust referral system by the Berrien County Juvenile Court. That's where we get most of our referrals for TNDA. All right. As prevention specialists, we continue to do alcohol, tobacco, and other drug presentations. And one of our newest programs is called Prevention Plus Wellness. The sport program offers alcohol prevention. Then you also see vaping, marijuana, and opioid. These are one session lessons, which was helpful in the pandemic because our usual Michigan model, which needs to be revised, was a 6-session program. And as you can imagine, schools starting this year probably had to come out with a lot of hybrid schedules. Some of them were all virtual. Some of them were physical. We were able to initiate this program at Hollywood Elementary virtually earlier this year, even though their students were on site in the school. So this also is one of the most popular emerging programs, and it promotes physical activity, healthy eating, sleep, stress control, spiritual practices, racial justice, goal setting, and positive identities. We just bought these 4 programs, but as you can hear, there are many other aspects of this program available. And then finally, we are in the middle of doing our alcohol and tobacco vendor education and compliance checks. We did have to put a stop on this last year because of the pandemic as well, but our team, actually we have 402 alcohol retailers, 180 tobacco retailers, and then a combination of about 275 that sell both. And so we work directly with retailers and providing education on the Youth Tobacco Act and also not selling alcohol to minors based on the Michigan Liquor Control Commission. So we do that education, and then based on that education, we partner with law enforcement agencies to go in and do compliance checks. I hate the word sting operation, but that's what they were known for many years. And so we do this education based on material that we've received from our funder, from SWIMBA, to conduct. We do a monthly forum, which we're now going to be offering virtually. And then we do individual vendor visits as well. So we want to make sure that our alcohol and retailer population, alcohol and tobacco retailers, are aware of compliance and compliance issues. And lastly, we're in the middle of SINAR. For those of you that don't know what SINAR is a way that the state determines the PA2 money that we're going to get. And it consists of non-consummated buys of cigarettes. And each county is given a certain number of compliance checks to do. And we administer those with our youth decoys. And then we report our findings as a county to the state. And the state has to have an overall 85% compliance rate to receive the PA2 money that we all hold so dear and is so valuable. So that's just a quick update for us.
Thank you. All right, Jillian, the dirt on weed.
Yeah, I'll be really brief here because I know we're short on time, but essentially, with Lisa coming into the public health promotion and prevention supervisor position, we had some really great conversation about how we could boost up some of the educational campaigns that are required by their grant funding even further than what had been done in the past. So there is a rotating quarterly focus on prescription medications, opioids, alcohol, tobacco, vaping, and marijuana. So we've been doing quite a bit more with some of these campaigns. I won't get into all of that because what I came to talk about today was more on the Dirt on Weed, which is an educational campaign regarding recreational and medical marijuana. So as Nikki had referenced earlier, we will be contracting with King Media. They are a marketing media company who helped us develop this campaign about 3 years ago. So this is the 3rd year that we'll be running this. We did receive that funding from Laura again this year. We will be continuing to partner with the Van Buren Community Mental Health Agency. Unfortunately, the Cass Van Buren Health Department did not receive the funding this year. So they were not able to partner with us. So it's more of a 2-county sort of venture this year, but definitely a better spread. And we're able to have a broader reach with that partnership. So as in the past, we have a couple of different focus areas with this campaign, namely youth prevention, which really does target parents of teens, of adolescents, giving information to those parents and encouraging them to have conversations with their teens about marijuana. And then pregnant and breastfeeding women, as well as safe storage and handling for those legal using adults, making sure that those products don't fall into the wrong hands. So this is going to be another great year of the campaign. We're excited to engage and start that even this month here in June and run the campaign through these summer months. It will be comprehensive. That includes print, social, digital, outdoor, so billboards, radio spots. We have a website landing page, that thedirtonweed.com, where a lot of people are driven to in those ads. And we also are going to be able to do some television ads again this year. Last year was the first year we were able to do that. With the pooled funds with our partners over in Van Buren, we are able to just afford a little bit more and get our message out there further than most of the time when we have limited funds for these sorts of educational campaigns. So we're excited for that. And that's all I came to share about today. So I can take any questions. I'm sure Lisa would be happy to take some too.
I have a question then, I guess, and that would be, is there any way to, probably isn't, but to monitor the effectiveness of all our initiatives, data, like for the at-risk population or just in general, to be able to see, are we having an impact from all our efforts? I guess the second question, I've read, I'm not on top of this, but I know Benton Harbor, the city, has gone back and forth on whether they're going to have a retail outlet or grow it there or something or another. I don't know what the status of that is at present.
I can answer the question about each of the programs that we do, especially are all evidence-based, so they have a pre and post-test component, as well as the TNDA program with the selective and high-risk youth. That also has a modified assist program that goes even a little deeper than what your average pre and post-test survey has. And so we have data, if you want me to get that all collected, but we have data on all of the programs that we administer, because that's also part of the requirements of our funder, to make sure that we're analyzing that. As far as I know, the city of Benton Harbor has contracted with NOBO, which is the name of the facility. I'm not sure if it's yet open to the public. I know the grow operation there is in full swing. Someone else may have some additional information.
Yeah, thank you. At some future point, it would be interesting to see, kind of the outcomes of this.
Yeah, maybe, Joe, we can ask Ms. Lisa to follow up with some information to the board when you have a minute. I also know that Ray has a quick question before we move on to Dr. Harrison's update.
Real quick, either Jillian or Lisa, from the campaigns that we have, is there a portion of that that goes in, that presents the illegalities also associated with marijuana use? Or is it all try to just stop at the prevention side and that's it?
Well, our particular funder is more from a prevention side. So our campaigns are not really confrontational as some campaigns could be. We're sticking more with the prevention message and what we can do to assist parents, what we can do to assist caregivers, kind of coming from that side of it.
Okay, thanks, Lisa.
Sure.
All right, if there are no more questions, Dr. Harrison, would you bring us up to date on the Berrien County Board of Commissioners activities?
Sure, we've been busy handling all of the contracts and agreements from the health department. So that's been half of the job at the county level. And we've also been focusing on reopening efforts, not just for the various county buildings, but also the Open Meetings Act compliance, and then how the board might transition to face-to-face meetings down the road. So naturally, I think you all appreciate none of those have clear direction, guidance, and we have conflicting messages from various state and federal level agencies. So we're just kind of muddling our way along with those, and hopefully we'll be able to give some clear guidance to people in the coming weeks. We do very much appreciate the hard work by the health board and the staff at the health department. Each of the commissioners repeatedly bring up the positive comments they've gotten from their constituents regarding the vaccination programs and efforts by our staff, and so how well they're all treated. So our compliments to the health department. So that would conclude my report.
Thank you. Thank you also for being on the interview committee for the medical director. We appreciated the time you took to do that. So
my pleasure.
Just a note that I've never seen 3 sewage appeals, but we have 3 sewage appeals today. So that ought to be fun. Are there any other Board of Health discussion items, or can we move to any public comment that we might have, Jillian, or questions?
Peg, if I may, just the one thing to mention is I do believe that things are on track, that starting July 1, that the Board of Commissioners and subsidiary boards, of which the Board of Health, will be moving towards in-person meetings. So things could happen over the next month, and we'll definitely keep you posted, but we will plan to have our next meeting in person. As things evolve in that direction, we'll keep you posted.
Is that a Niles meeting?
We are typically in Niles in July. I do know that the courts have been utilizing Niles more because there's some more space for juries and to be a little bit more spread out. So we will have to work through what the venue is, if we will indeed be Niles or if we will need to be in Benton Harbor, but we'll let you all know with ample time.
Thank you. Jillian, are there any public comments or questions?
There are no public comments.
All right, hearing none, we are adjourned. Thank you all for being here.